Pathology for Physical Therapy Assistant, 2nd edition. Chapter 4, The Immune System, page 84. Immunology is the study of the physiologic mechanisms that allow the body to recognize material as foreign and to neutralize or eliminate them. When the immune system is working properly, it protects the organism from infection and disease. When it is not, the failure of the immune system can result in localized or systemic infection or disease. In fact, the significance of a healthy immune system is apparent in states or diseases characterized by immunodeficiency, such as occurs in human immunodeficiency virus, HIV infection, or in people on immunosuppressive medication. Without an effective immune system, an individual is at risk for the development of overwhelming infection, malignant disease, or both. Not all immune system responses are helpful, as in the case of organ or tissue transplant rejection. In addition, excessive or inappropriate activity of the immune system can result in the hypersensitivity states, immune complex disease, or autoimmune disease. For a complete understanding of the immune system as it relates to injury, inflammation, and healing, the reader is encouraged to read this chapter along with Chapter 3. Types of immunity. Innate and acquired immunity. Two types of immunity are recognized: innate immunity, natural or native immunity, and acquired immunity, adaptive or specific immunity. Innate immunity acts as the body's first line of defense to prevent the entry of pathogens. Two non-specific, non-adaptive lines of defense are involved in innate immunity. Non-specific refers to the fact that this part of the immune system does not distinguish among different types of invaders, bacteria, fungus, virus, and is non-adaptive. That is, it does not remember the encounter with specific invaders for future encounters. Each time that potential pathogens is introduced, the innate immune system reacts in the same way, in the same predictable manner. The first line of defense is the skin and its mucosal barriers, and the second is a non-specific inflammatory response to all forms of cellular injury or death. Innate responses occur to the same extent no matter how many times the infectious agent is encountered, figure 4.1. Acquired immunity is characterized by specificity and memory. The primary role of the immune system as a more specific line of defense, acquired immunity, is to recognize and destroy foreign substances such as bacteria, viruses, fungi, and parasites, and to prevent the proliferation of mutant cells such as those involved in malignant transformation. This type of immunity results with when a pathogen gains entry to the body and the body produces a specific response to the invader. Acquired immunity has a memory, so that when the same organism is encountered again, the body can respond even more rapidly to it and with a stronger reaction. The two components to acquired immunity, humoral immunity and cell-mediated immunity, are discussed in greater detail later in the following section. Acquired immunity, active or passive immunity. Acquired immune responses can occur as a result of active or passive immunity. Active immunity includes natural immunity and artificial immunity, which is intended or deliberate. Active acquired immunity refers to protection acquired by introduction, either naturally from environmental exposure or artificially by vaccination, of an antigen, microscopic component of a pathogen that causes an immune response, into a responsive host. The concept of vaccination is based on the fact that exposure to a harmless version of a pathogen generates memory cells, but not the disease the pathogen causes. The immune system becomes primed with strong and immediate protection if the pathogen or microorganism is encountered in the future. Some of the most promising prophylactic and therapeutic vaccine strategies are currently being investigated for malaria, cancer, HIV, asthma, influenza, diabetes, hepatitis C, and many other diseases. For example, the transplacental transfer of antibodies from mother to fetus, the transfer of antibodies to an infant through breast milk, or the administration of immune serum globulin, Y globulin, provides immediate protection but does not result in the formation of memory cells and therefore provides only temporary immunity. This type of immunity, passively acquired, lasts only until the antibodies are degraded, which may be only a few weeks to months. The immune response. External defenses. As a covering for the entire body, with the exception of any openings, the skin offers the first and best line of protection, see Figure 4.1, which is clearly demonstrated in cases of significant burns when infection becomes a major problem. The body openings also offer their own unique protections, such as lysosome in tears to kill bacteria, waxy secretions in the ear canal to prevent bacteria from advancing inside nasal hair, stomach acid, and unfavorable rapid pH change as the gastroduodenal junction to protect against ingested organisms, protected low pH vaginal secretions, acidic urine, and so on. When organisms enter the body by penetrating the epithelial surface of the respiratory, gastrointestinal, GI, or genitourinary tract, biochemical defenses offer additional protection in the form of medication, phagocytes that engulf and destroy foreign particles, and NK cells that attack and destroy viruses in infected cells and tumor cells. Phagocytes. Phagocytes are involved in non-specific or innate immunity. These cells readily eat, ingest microorganisms such as bacteria or fungi and kill them as a means of protecting the body against infection. The two principal phagocytes are neutrophils and monocytes, which are white blood cells, WBCs, or leukocytes. The 5 types of leukocytes are neutrophils, eosinophils, basophils, monocytes, lymphocytes. Because of their granular appearance, neutrophils, eosinophils, and basophils are collectively referred to as granulocytes. Granulocytes are short-lived, 2 to 3 days, compared with monocytes and macrophages, which may live for months or years. Phagocytes immigrate out of the blood and into the tissue in which an infection has developed, and each of these cell types has specific phagocytic function in the immune system. Neutrophils, eosinophils, basophils, and monocytes are classified as phagocytic leukocytes that function in non-specific or innate immunity. A severe disease in the blood level of these cells is the principal cause of susceptibility to infection in people treated with intensive radiotherapy or chemotherapy. These treatments suppress blood cell production in the marrow, resulting in deficiencies of these phagocytic cells. Neutrophils, also referred to as polymorphonuclear cells, PMNs, derive from bone marrow and increase dramatically in number in response to infection and inflammation. Neutrophils can directly kill invading organisms, but may also damage host tissue. In the process of phagocytosis, bacteria or debris is engulfed and then digested by enzymes contained within the neutrophils. Neutrophils die after phagocytosis. The accumulation of dead neutrophils and phagocytosed bacteria contributes to the formation of pus. Monocytes circulate in the blood, but when they migrate to tissue, they mature into macrophages, or macrophage, which means large eaters. The engulfment of a pathogen by a macrophage is an essential first step leading to a specific immune response. After neutrophils kill the invading organisms and the process of phagocytosis has begun, macrophages appear to clear up the debris produced by the neutrophils and to kill any damaged but not dead bacteria or bacteria that are too large for the neutrophils. After phagocytosis, in the case of macrophages, digest the pathogens, antigenetic material appears on their surface to identify them as foreign invaders. In this process, macrophages introduce the pathogen to lymphocytes. Microscopically, T lymphocytes appear identical, but they can be distinguished by means of distinctive molecules called cluster designations, CDs, located on their cell surface. For example, all mature T cells carry markers known as T2, T3, T5, and T7, or CD2, CD3, CD5, and CD7. CD4 lymphocytes are the T helper cells, and T8, CD8 lymphocytes are cytotoxic T cells. Other T lymphocytes are identified as NK cells for their ability to kill certain tumor cells and virus-infected cells. Macrophages release a chemical messenger, interleukin-1, IL-1, to promote T4 lymphocytes to recognize that they have ingested a pathogen. Once the lymphocytes are aware of the pathogen, they will trigger a specific immune response. ILs are one type of cytokine, a protein released by macrophages to trigger the immune response. See the discussion of cytokines later in this section. Some of the multiple functions of IL-1 include increasing the temperature set point in the hypothalamus, increasing serotonin in the brainstem and duodenum, causing sleep and nausea, respectively, stimulating the production of prostaglandins, leading to a decrease in pain threshold, resulting in the myalgias and arthroglias, increasing the synthesis of collagenesis, resulting in the destruction of cartilage, and most important, kicking the T4 cells into action. Macrophages also participate in the defense against tumor cells and secrete numerous molecules that assist in the immune and inflammatory response. Stimulation of macrophages, can boost the immune response. Eosinophils are the next group of leukocytes that participate in the innate immunity process. Eosinophils are derived from bone marrow and multiply in both allergic disorders and parasitic infestations. When organisms are too large for neutrophils and macrophages, eosinophils get within close proximity of the invading organism and release the contents of their granules to kill them. Basophils and mast cells are white blood cells, leukocytes, that circulate in the peripheral blood and function similarly to mast cells in allergic disorders. Basophils and mast cells are located close to blood vessels throughout the body and have similar functional characteristics. Mast cells contain histamine, which dilates blood vessels when released. I can't believe it took me almost 15 minutes to read these 2 pages. Mast cells, page 86. Mast cells are derived from stem cells and travel in the blood in such small numbers that they are not recognized as blood cells. Basophils and mast cells cause an increase in blood supply in the area where the bacteria or viral antigen is located. This increase in circulation brings more phagocytes to the area. Inflammatory mediators. The complement system and interferons act as mediators of the inflammation. Along with phagocytes, they destroy organisms that breach the first line of defense. The complement system consists of 20 proteins that are key components in acute inflammatory response designed to enhance immune function. When activated, these proteins interact in a cascade-like process to assist immune cells by coating microorganisms so they can be more easily phagocytosed. These also participate in bacterial lysis. In some cases, the invading organisms are eliminated from the body. Sometimes the inflammation produced by the complement cascade immune response walls off the microorganisms by forming, for example, a cyst or tubercle that protects the rest of the body from infection. A second group of mediators in the cytokines, especially interferons, they act as messengers both within the immune system and between the immune system and other systems of the body, forming an integrated network that is highly involved in regulation of immune responses. Once a cell becomes infected by a virus, certain genes in the cell that produce interferons are turned on. Interferons coat the surrounding uninfected cells, making them viral resistant. Natural killer cells. Natural killer NK cells are large granular lymphocytes that function to kill viruses, other intracellular microbe-infected cells, and tumor cells. NK cells respond by releasing cytotoxic granules and by secreting cytokinin. Acquired immunity. To establish an infection, the pathogen must first overcome numerous surface barriers and the innate immune responses. Figure 4.1. In these cases, acquired immunity is tailored to recognize each different type of organisms and kill it. The two types of acquired immune responses that occur are humoral immunity and cell-mediated immunity. Highlight that. Although these two responses are often discussed separately, they are two arms of the immune system and work together. Failure in one can alter the effectiveness of the other. These two types of responses overlap and interact considerably, but the distinction is useful in understanding how the immune system is activated. Humoral immunity. Humoral immunity response. See, I'm already tired of reading this book. The humoral immune response is mediated by the antibodies present in different body fluids, such as saliva, blood, or vaginal secretions, such as those produced by B lymphocytes. B lymphocytes, or B cells, are called such because they originate in the bone marrow and they circulate throughout the extracellular fluid. Antibodies produced by B lymphocytes are very effective against organisms that are free-floating in the body that can be easily reached and neutralized. The surface of the B lymphocytes is coated with immunoglobulin, Ig, and each B cell has a receptor and antibody that recognize a specific foreign substance or antigen. When this happens, B cells change into protein synthesizing cells known as plasma cells and memory B cells. This plasma cell produces and secretes into body fluids a specific antibody to the antigen. Memory cells produced in connection with humoral immunity circulate among the blood, lymphoid system, and tissues from about 1 year or even longer. They are responsible for the more rapid and sustained, stronger immune response that occurs with repeated exposure to the same antigen. This humoral response is particularly useful in fighting bacterial infection. The type of antibody produced depends on genetic variability, the specific antigenic stimulus, and whether it is first or subsequent exposure to that antigen. The humoral immune response is more rapid than the cell-mediated response and is more often a factor in resistance to acute bacterial infections. Humoral immunity can be transmitted to another person either by inoculation or by maternal transfer via placenta or breast milk. This transfer is called passive immunity. Cell-mediated immunity. Some organisms, all viruses and some bacteria, actually hide inside cells where antibodies cannot reach them. Sneaky. A second arm of the immune system called cell-mediated immunity uses T lymphocytes, which can recognize hidden organisms, search them out, and destroy them on a cell-to-cell basis. Lymphocytes originate from stem cells in bone marrow and differentiate or mature into either B or T cells. T lymphocytes or T cells are called such because the precursors of these cells start from the bone marrow but then mature in the thymus, located right behind the sternum, where they learn to discriminate self from non-self, figure 4.2. Both T and B lymphocytes continuously circulate through blood, lymph, and lymph nodes. After interaction with a specific antigen, the activity of lymphocyte produces numerous additional lymphocytes called sensitized T cells. This T cell subpopulation has several functions, including 1, helping B cells enhance the production of antibodies, 2, activating macrophages and helping them destroy large bacteria, 3, helping other T lymphocytes recognize and destroy virally infected cells, and 4, helping NK cells kill infected cells, figure 4.3. The immune system also consists of a regulatory and suppressor T cells. Regulatory and suppressor T cells, CD4 plus, CD25 plus, which suppress activation of the immune system and prevent pathologic self-reactivity or autoimmune disease. Cell-mediated immunity is responsible for the rejection of transplanted tissue, delayed hypersensitivity reactions, contact dermatitis, and some autoimmune diseases. Cell-mediated immunity is the basis for many skin tests. Tuberculin test, allergy testing. Cellular immunity cannot be transferred passively to another person. Conditions known to affect T cell number or responsiveness includes HIV infection, acquired immunodeficiency syndrome, AIDS, stress, malignancy, general anesthesia, thermal injury, surgery, diabetes, and immunosuppressive drugs, including corticosteroids. Other adults age 65 and older show reduced numbers of circulating lymphocytes, and malnourished people show defects in most tests of T cell function. Summary of the immune response. The immune system has evolved to protect multicellular organisms from a vast array of threats. Immunology is the study of how the immune system works and the consequences of its dysfunction. Through past and present research on various immune system mechanisms, ways in which the immune system can be manipulated to benefit the host are being discovered. The principal function of the immune system is to eliminate infectious agents and abnormal self-components, cancer cells, without attacking the body's own tissue. The immune system must maintain a state of balance such that when an external or internal threat is encountered, an appropriate response is generated to control the invader, and then the system returns to equilibrium. This encounter with a particular insult educates the immune system to produce memory so that upon re-encountering a foreign invader, it reacts more rapidly and with a strong response. Most pathogens and antigens are encountered after they have been inhaled or ingested. See figure 4.2. Keeping in mind that innate immunity and acquired immunity functions in tandem, and that within the acquired immune system, humoral immunity and cellular immunity are also working simultaneously. A variety of immune responses can occur when an extracellular pathogen attempts to invade the body. If the pathogenic organism gets past the first line of defense, innate immunity, and it is presented to the body, the following happens. 1. A B lymphocyte recognizes its bacterium and produces antibodies that bind to it and neutralize it. Humoral response. 2. A T lymphocyte recognizes it as a bacterium and produces cytokines to help the macrophages lyse and phagocytose the bacteria. Cell-mediated response. 3. In the case of a virus, a cytotoxic T lymphocyte can recognize the cell and destroy it. Cell-mediated response. And 4. The complement system can recognize the invading organism and destroy it. Innate immunity. Dysfunction of the immune system can contribute to diseases. 2 types of genetic alterations could lead to abnormalities. 1. Mutations that inactivate the receptors or signaling molecules involved in innate immunity, and 2. Mutation that render them active all the time. The first type of mutation would result in immunodeficiency. The second type of mutation triggers anti-inflammatory reactions and thereby contribute to a variety of conditions with an inflammatory component: asthma, allergies, arthritis, autoimmune diseases. Factors affecting immunity. In addition to the effects of aging, other factors can affect the immune system. These factors may include nutrition, environmental pollution, and exposure to chemicals that influence the host's defense, prior or ongoing trauma or illness, medication, page 88, splenectomy, removal of the spleen, influences of enteric, endocrine, and neurochemical systems, stress, and psychological, spiritual well-being, and socioeconomic status. These factors, as well as clinical conditions that contribute to immunocompromised state, are listed in box 4.1. Sleep deprivation has also been known to have an important effect similar to the effects of stress on the immune system by reducing cellular immunity. Some factors do not alter the immune system directly but increase a person's exposure to pathogens. New information is being discovered about the sensory functions of the intestines and how neural, hormonal, and immune signals interact. The gut immune system has 70% to 80% of the body's immune cells, and the protective blocking action of the secretory response in the gut is crucial to the integrity of the GI tract, immune function, and host defense. Nutritional status has a profound effect on immune function. Nutrients have fundamental and regulatory influences on immune response of the GI tract and therefore on host defense. Reduction of normal bacteria in the gut after antibiotic treatment or the presence of infection may interfere with the nutrients available for immune function in the GI tract. Severe deficits in calories, protein intake, or vitamins such as vitamin A or E can lead to deficiencies in T cell function and numbers. Deficient zinc intake can profoundly depress both T and B cell functions. Zinc is required for at least 70 different enzymes, some of which are found in lymphocytes and are necessary for their function. Dietary changes may alter aspects of immunity, although research in this area is ongoing. In addition, Morbid obesity may alter the immune system by creating a vulnerability to certain diseases, including cancer. Some medications, cancer chemotherapeutic agents, profoundly suppress blood cell formation in the bone marrow. Other drugs induce immunologic responses that destroy mature granulocytes. Many drugs also affect B and T cell functions, especially against antigens that require the interaction of T cell and B cells for antibody production. These complications have been observed since the advent of corticosteroids and chemotherapeutic drugs as treatment for people with autoimmune disease, transplants of cancer. Depression of B and T cell formation is manifested as a progressive increase in infection with opportunistic microorganisms. Surgery and anesthesia can also suppress both T and B cell function for up to 1 month post-operatively. Because of the invasive nature of any surgical procedure and because defects in immunity have been described in most major illnesses, it is logical to assume that the majority of hospitalized surgical clients are immunocompromised to some degree. Surgery to remove the spleen results in depressed humoral response against encapsulated bacteria, especially Streptococcus, pneumoniae, Haemophilus influenzae, Staphylococcus, the group A Streptococcus and the Neisseria meningitis, burns. Burns cause increased susceptibility to severe bacterial infection as a result of decreased external defense, intact skin. Neutrophil function, decreased complement levels, decreased cell-mediated immunity, and decreased primary humoral responses. Blood serum from clients with burns also contains nonspecific immunosuppressive factors that will suppress all immune responses regardless of antigen involved. The relationship among stress, psychosocial, spiritual well-being, and socioeconomic status and susceptibility to disease through depressed immune function has become an area of intense research interest. In the past, there were anecdotal reports of increased incidence of infection, disease, and malignancy associated with periods of both intense and relatively minor stress. Exercise immunology. The effect of physical activity and exercise, aerobic, endurance, and resistance on the immune system and neuroimmune systems has been an area of research interest. A brief summary of the results is presented here, but a more detailed accounting of exercise in the immune system and future direction for studies is available. Depending on the intensity, activity, or exercise can enhance or suppress immune function. In essence, the immune system is enhanced during moderate exercise. Moreover, regular, moderate physical activity can prevent the neuroendocrine and detrimental immunologic effects of stress. In contrast to the beneficial effects of moderate exercise on the immune system, strenuous or intense exercise or long-duration exercise such as marathon running is followed by impairment of the immune system. Intense exercise can suppress the concentration of lymphocytes, suppress NK cell activity, and leave the host open to microbial agents, especially viruses, which can invade during this open window of opportunity and may lead to infection. Extreme and long-duration strenuous exercise appears to lead to deleterious oxidation of cellular micromolecules. The oxidation of DNA is important because the oxidative modifications of DNA bases are mutagenic and have been implicated in a variety of these diseases, including aging and cancer. Effects on neutrophils and macrophages. Exercise triggers a rise in blood levels of neutrophils, PMNs, and stimulates phagocytic activity of neutrophils and macrophages. The exercise invoked increase in the PMN count is greater if the exercise has an eccentric component, such as downhill running. If the exercise goes beyond 30 minutes, a second or delayed rise in PMNs occur over the next 2 to 4 hours while the exerciser is at rest. I'm just going to read that again. Exercise triggers a rise in blood levels of neutrophils and stimulates phagocytic activity of neutrophils and macrophages. The exercise evoked increase in the PMN count is greater if the exercise has an eccentric component, such as downhill running. If the exercise goes beyond 30 minutes, a second or delayed rise in PMNs occurs over the next 2 to 4 hours while the exerciser is at rest. The delayed rise in PMNs is probably the result of cortisol, which spurs release of PMNs from the bone marrow and hinders the exit of PMNs from the bloodstream. After brief, gentle exercise, the PMNs count soon returns to baseline, but after prolonged strenuous exercise, this returns to normal may take 24 hours or longer. Effect on natural killer cells. Most researchers agree that the number of NK cells and the function or activity of these cells in the blood increase during and immediately after exercise of various types, duration, and intensity. This phenomenon refers to as NK enhancement, is temporarily and seems to be the result of a surge in epinephrine levels and from cytokines released during exercise. NK enhancement by exercise occurs in everyone regardless of sex, age, or level of fitness training. Once a person is accustomed to a given exercise level, however, the NK enhancement falls off, suggesting it is a response not to exercise per se, but to physiologic stress. After intense exercise of long duration, the concentration of NK cells and NK cytolytic activity declines below pre-exercise values. Maximal reduction in NK cell concentration and lower NK cell activity occurs 2 to 4 hours after exercise. Although this depression in NK cells count seems too brief to have major practical importance for health, there may be a cumulative adverse effect in athletes who induce changes several times per week. Further study is warranted before specific exercise guidelines are determined. Effect on inflammatory response. Regular moderate exercise as well as resistance training and long-lasting endurance exercise is known to induce pro-inflammatory cytokines. Brisk exercise, even brief heavy exertions such as maximal bicycle ergometry for 30 or 60 seconds increases the white blood cell count in proportion to the effort. This exercise is induced This exercise induced increase in white blood cell count, including lymphocytes and NK cells, is largely the result of mechanical effects of an increased cardio output and the physiologic effects of a surge in serum epinephrine concentration. The number of cells that enter the circulation is determined by the intensity of the stimulus. The number of lymphocytes in the circulation increases during exercise, but decreases below normal levels for several hours after intense exercise. Decreased number of lymphocytes are associated with decreased lymphocyte responsiveness and antibody response to several antigens after intense exercise. Effect on cytokines. Strenuous exercise defined as exercising at the minimum of 80% of maximal oxygen consumption can suppress immune function. Regular exercise protects against diseases associated with chronic low-grade systemic inflammation. However, this long-term effect of exercise may ascribe to the anti-inflammatory response elicited by a short-term bout of exercise. All right, special implications for the PTA. Exercise immunology. PTAs use exercise in the treatment of patients of all ages with a variety of clinical problems, thereby influencing immune function. Exercise as means of preventing illness and attaining a healthy lifestyle and as an intervention tool in immunodeficiency stress is becoming a larger part of preventative services. Research in the area of exercise immunology is growing. Keeping abreast of research results is the first step to examining the clinical implications in the area. Aged adults constitute a growing and important consumer group of therapy services. Because immune function declines with advanced age, it is important that we understand the effects of exercise on immune function. Very few absolute guidelines have been developed. It seems that intense or strenuous exercise may be detrimental to the immune system, whereas a lifetime of moderate exercise and physical activity enhances immune function. Further, research is needed to clarify or modify this guideline. It takes 6 to 24 hours for the immune system to recover from acute effectiveness of severe exercise. Each individual client must be evaluated after exercise to determine the perceived intensity of the exercise or intervention session. For example, in the deconditioned older adult with compromised cardiopulmonary function, reduced oxygen transport, and impaired mobility, ambulating from the bed to the bathroom may be perceived by his or her body as strenuous exercise. Although intense exercise causes suppression of immune parameters in young subjects, data from aged animals and human beings show that intense exercise has no detrimental effects on immune function or rate of infection in older adults. Thus, relatively intense exercise programs may be prescribed that could maximize cardiopulmonary and multiskeletal function without impairing immune function in the frail elderly people. Nevertheless, intense exercise during an infectious episode should be avoided. A neck check should be conducted for anyone, especially a competitive athlete who wonders whether to exercise in the presence of an acute viral or bacterial infection. If the symptoms are located above the neck, such as a stuffy or runny nose, sneezing, or scratchy throat, exercise should be performed cautiously through the scheduled workout at half speed. If after 10 minutes the symptoms are alleviated, the workout can be finished with the usual amount of frequency, intensity, and duration. If instead the symptoms are worse and the head is pounding or throbbing with every footstep, the exercise should be stopped and the person should rest. If a fever or symptoms below the neck are evident, such as aching muscles, hacking cough, diarrhea, or vomiting, exercise should not be initiated. Immunodeficiency diseases. In immunodeficiency, the immune response is absent or depressed as a result of the primary or secondary disorder. Primary immunodeficiency reflects a defect involving T cells, B cells, or lymphoid tissue. Secondary immunodeficiency results from from an underlying disease or factor that depresses or blocks the immune response. Primary immunodeficiency. The recognition of impaired immunity in children 50 years ago has resulted in a tremendous increase in knowledge of the functions of the immune system. More than 95 inherited immunodeficiency disorders have now been identified. Genetically determined immunodeficiency can cause increased susceptibility to infection, autoimmunity, and increased risk of cancer. The defects may affect one or more components of the immune system, including T cells, B cells, NK cells, phagocytic cells, and complement proteins. No further discussion of these conditions is included in this book because the PTA rarely encounters these congenital conditions. A review of the pathophysiology of primary immunodeficiency is available. Secondary immunodeficiency. Secondary immunodeficiency disorders such as leukemia and Hodgkin's disease follow and result from an earlier disease or event. Defects in the immune defenses occur in the viral infections or other infections, malnutrition, alcoholism, aging, autoimmune disease, diabetes, mellitus, cancer, chronic disease, steroid therapy, cancer, chemotherapy, and radiation. More specific causes, such as AIDS, are also contribute to secondary immunodeficiency. I'm going to stop here at page 90 and take a break.